Sejam todos bem-vindos e bem-vindas. Para formar e pôr em ação fisioterapeutas de excelência nas nossas UTIs, está entrando no ar mais um episódio do podcast UTI em Forma em Ação. Hoje vamos atravessar fronteiras, mais uma vez, e por isso, a partir de agora, o nosso episódio será conduzido em inglês. Caso seja necessário, você pode ativar as legendas de tradução automática no vídeo do YouTube para nos acompanhar. We are on air with a new episode of the podcast UTI em Forma e Ação. Everyone can watch us on YouTube, or you can listen to us on Spotify. And don't forget to subscribe and leave your comments so we can achieve more and more people. Today, we have a great honor to welcome professionals who are global references for all of the intensive care physical therapists. We are going to cross new frontiers and talk to Michelle Kho and Bronwen Connolly. And I'm going to introduce our guests and briefly, and then we can bring space for you to tell about your work. Michelle Kho is an ICU physiotherapist at St. Joseph's Healthcare and an associate professor in the School of Rehabilitation Science at McMaster University, both in Hamilton, Ontario, Canada. And Bronwen Connolly is an academic critical care physiotherapist and a senior lecturer in critical care at Queen's University in Belfast. Welcome, both of you. It's a great honor to have you here.
Thank you. It's a pleasure to be here, and thank you for inviting us.
First, we would like to thank you very much for your time. I and Saint-Clair have been working a lot for the ICU rehabilitation development in Brazil, and your papers have been used as an important reference by Brazilian physiotherapists. Therefore, it's very exciting for us listen your knowledge and expertise here in our podcast. Welcome and thank you very much. Okay, so let's start. Recently, you have published two very interesting papers together from street bed rest to early mobilization and the physical rehabilitation on ICU, past, present, and future. By the way, Ricky Gosselin was with us in the podcast, and he talked about these papers and recommended for all the physiotherapists. Can you talk a bit about what has motivated you both to write about this topic, about these papers?
Bronwen, would you like me to start?
Go for it.
Sure. So thank you so much for the invitation to be here. And it's really, I think, the highest compliment that our work is being used. We were invited by Hannah Wunsch to contribute a paper to her journal on the history of ICU. So it was a really great opportunity to look at understanding the profession of physiotherapy and its contributions to the intensive care. So it was really fun for Bronwen and I to work together and reflect back on how the field of critical care has changed over time, and in parallel, review how the field of physiotherapy has also evolved. Subsequent to that paper, we were invited by Intensive Care Medicine by Lavina Munshi to build on that paper, and we had the opportunity with Sue Burney to further reflect on now. We've reflected on physiotherapy, but what can we consider around ICU rehabilitation and where the field could go?
It's interesting because as you told in the history, it's the need of the papers of the how do you say, the magazines and the articles, the intensive care and the other one. It's their need to talk about the history and what do we expect for the physical therapy and the rehabilitation in the ICU in the future. And that's what you brilliant show in the paper, that we didn't think about that before. We had the problems and we started at probably in 1990 or probably next to 2000. And then we started to notice that it was an important field that needed more evidence and more scientific papers and more working on the area. So it's really interesting to listen here from you that you were someone looked for you to write about this, and that's really important for the profession.
I think it highlights how important physiotherapy is considered by our colleagues in critical care. So as Michelle highlighted, we were asked to the first paper around the history, in being invited to contribute that, I think highlights how our colleagues, our medical colleagues, valued that physiotherapy is and has continued to develop as a key profession and requirement for patients in ICU, as well as the various medical specialties within critical care and the different aspects of medical treatment. Actually, it was lovely that they, to be part of that, to recognize how much our contribution is important to the care that we deliver to patients. And I think Michelle and I were keen to make sure that we tried to cover the clinical development and also how our research has developed as well over time. And sometimes clinical practice develops very quickly, and then, as you said, Saint-Clair, we catch up with some of the evidence. And we wanted to try and cover some of that as well, that there are still gaps in our knowledge, and we are doing excellent clinical practice, but how can we improve upon that with our research as well?
I think you start the paper, the one of the papers, the physical rehabilitation in the ICU, with something that we talk a lot here, that our intervention is complex. It's inside a place that's complex. So that's what you just said, Bronwen, that we develop in the clinical practice, but we need to catch up. We need to follow what we are doing with scientific evidence, so we can bring a better assistance for the critical care patient.
I think there's also it may appear from an outsider's perspective that we are doing the same things with different patients. However, from a physiotherapy perspective, there's so much complex decision making that goes into deciding what we're going to do with a patient, particularly in the intensive care unit. And I think Rick did a really wonderful job in episode 56 to describe the different types of clinical decision making and background that we need in order to care for critically ill patients.
He did it.
Thinking about this, when you was writing the papers, which are the main transformations you see happening on clinical practice when compared today to the past? What's the global visual about this?
Can I just check, Deborah, do you mean what was our kind of approach to thinking about the global
Yes.
Well, I guess so. We kind of felt that Michelle and I both represent two international countries with our experience, and so our practice has some commonality between Canada and the United Kingdom, and we also have had the opportunity to work with other colleagues from other international settings during our careers. So we're trying to draw upon different experiences, of how physiotherapy has developed around the world. So we know that our practice shares a lot of common elements, but actually in some settings, healthcare settings around the world, there may be some differences as well. And that can be because of the healthcare system overall. It can be some differences in training. It can be some differences in the role of the physiotherapist and their autonomy around what they're allowed and their remit of practice. And I guess we wanted to try and draw upon some of that in how we describe the history. And actually, it's really interesting. Rick commented on a couple of studies that actually, when he read it after, he said to us, "Oh, there's a couple of other studies I'm surprised you didn't mention." So we kind of could have gone all day. We're actually just drawing upon some individual aspects. So we had to kind of do a brief summary, but we really could have spent a lot longer in in some of the particular areas, comparing and contrasting between countries and how the profession has developed. But I think we were keen to try and draw upon overall what was common within the professions, and what were the key milestones that kind of helped the profession move forwards in critical care.
Great. We talk a lot about the profile of the physical therapist, of the physiotherapist here, and we also asked Rick about that. And as you reach it to the history, and you have been in the past, and you are in the present, and you have expectations for the future, what do you think that a physiotherapist that works or wants to work in the ICU needs as main abilities to make a better profile for the physiotherapist in the ICU? What do you think that we need to stimulate and to work on people so we have a better profession?
That's an excellent question, because what's really great about the training that we have as physiotherapists is that we have clinical skills, and we're very creative, and we solve lots of problems fairly easily without making it look like a big deal. So I think for physiotherapists to increase their profile, will need to understand the physiology and the conditions that are amenable to physiotherapy in the intensive care unit. We need to understand the emerging trends, and we need to have curiosity to expand how we can contribute as a larger part of the team. Right now, I think we're involved in early mobility or rehabilitation activities, airway clearance and respiratory, as Rick mentioned. And I think we can also play leadership roles in research and contribute to other parts of the humanness of people in the ICU. I think, first of all, we need to remember that the people who are caring for are people first, and that they have lives to get back to. And if we can think about that person, then we can provide personalized care that is meaningful to them.
I would agree. And I just, Michelle picks up some really valuable characteristics that I think we have, because we're an excellent profession with our interpersonal skills. It's such a, in terms of the therapy that we deliver, it has that connection with patients, and you need to develop that rapport with people. It is such an interpersonal kind of therapy that we deliver. You're hands-on with patients, and restoring them to what they what they're used to. I wanted to add one thing actually to Michelle's comment about research leadership. Thinking as we move forwards in our profession, we will need to think carefully and reflect carefully on what do we really know works well, and what are the gaps in our knowledge, and not to be cautious or anxious about testing and exploring that. And it's, if we don't truly have the evidence for some of our treatments, we need to embrace that and say, how do we find the evidence and how do we develop that? And so to have equipoise around recognizing that we have developed clinical expertise, but if we want our profile to be valued and highly considered by our colleagues, then we also need to embrace research methods to underpin our practice. And in the same way that our medical colleagues and within our whole specialty look and test the different interventions that we're delivering, I think as physios, we will need to make sure that moving forwards, we welcome that within our profession, that we engage with that, and for that not to be threatening in any way. We should actually lead that and take that role.
I agree with that, and would like to add that it will challenge us to think about what outcomes we use. So we'll need to think about what intervention we're conducting, what outcomes we consider both short and long term, and specifically the relationship between the intervention that we're doing and an outcome that we're intending to affect. So we need to think both in a narrow horizon, but also in a longer term horizon to understand how our interventions are having an impact on people.
It's really great to hear that, because we have some discussions that we have had recently, and one of the discussions led us to a talk that the physiotherapists sometimes they believe the patient's gonna get better just because the physiotherapist is beside him and putting his hands or her hands on the patient, and that's not that simple. We need to understand and to bring evidence. So it, for me, I'm a teacher, I'm a researcher as well, and also Deborah is a teacher. Also, Deborah is a researcher here, and we work with graduation students for physiotherapy, and that's really great to hear that the future needs new evidence and scientific evidence to support what we do in a better way. And I also think that we know that the patient need mobilization or rehabilitation activities. We know that if we don't do that, the patient's gonna be in the ICU for a longer time, for a longer period, and it's gonna have impact on functionality and all that. But we don't know little things about the rehabilitation process that we need to clarify so we can make a better intervention, take better decisions. Maybe we are losing time in some intervention, and maybe we are just not giving the patient some simple intervention, as Michelle told it. We just know what to do, and it looks simple to other people, but we need to make better decisions.
And also that it's the beginning, the ICU, as we know, is only just one part of the patient's journey. And so I think we're talking a lot more now around the pathway of recovery for patients, and what we've focused a lot about in the intensive care unit. But I think some of the points that Michelle and myself and Sue have made in the second paper also apply to thinking about patients as they move through into recovery stages outside of the ICU as well, because they are still experiencing some of the challenges that they developed in the ICU, even if they're well enough to not need to be physically in ICU anymore. And Saint-Clair, just picking up what you were describing there around working closely with individual patients. I was hearing some work by a colleague from North America, Jason Falvey. He looks around the social setup that patients have and thinking about how does that impact their rehabilitation. And, a great description of, we like to measure things with patients like, a 6-minute walk test. And if you do that in the hospital, it's lovely because you've got, this wonderful corridor that people walk down. But that's not what someone's real world looks like in their home and in their community environment. So I think increasingly we will need to consider more broadly and bring that into how we rehab patients. So what does their home environment, their community setting look like? How do we help them navigate that area, not what our hospital setting looks like? So I think there's more and more it will be around the pathway for patients as they move from the intensive care unit.
It's such a good point, Bronwen, because we also need to think about getting them into the community and getting them back to their lives, because ICU is such a small part of someone's overall life journey. And can we get them back to participating in the activities that are important to them?
We had our 2 last episodes on the podcast. We talked about some things that just match with this. The last one we recorded. We talked about exercise physiology, and we were telling that not everything that we learn from exercise physiology is able to fit in the ICU patient. So we need to understand, but we don't have to do the same thing that we do in an athlete in the ICU patient. And the other episode, we talked about prognosis, and Deborah just talked about this, that we need to understand the social meaning of the rehabilitation. You can't just make someone strong in the ICU and you don't understand how is it his or her house, and does he take the bus, does he drive, does she walk, does she take care of children? What's the environment, social environment we are going to bring the patient back?
And we can start to find that out from patients and their loved ones in the ICU. There's nothing to stop us finding out that information, because that can also be a huge motivator for patients in those early stages. If they feel that we recognize what they're trying to get back to right from the very start, then it feels like it's a partnership about rehabilitation, that we're helping them to recover, rather than perhaps the feeling that the patient's in the ICU and we're doing some particular exercises, but there's no meaning to it. Whereas if the patient, perhaps reassuring the patient that we understand what their goal is and what their world looks like right from the start, it feels like we're recognizing that we need to do that more and more. As Michelle says, humanizing that.
Yeah.
Now I would like to talk about the other things. I would like to talk about the specific physical therapy interventions at ICU. What do you think is the best practice today now at ICU rehabilitation for critical care patients? When we look for the past and when we look at today now, what's the main changes in interventions, in rehabilitation interventions for critical patients, and what is the best practice today about physical or rehabilitation therapy strategies?
Michelle, do you want to?
Sure. So that's such a good question. I think we can say definitively that rehabilitation cannot be an afterthought, and rehabilitation can start in the intensive care unit. What is a bit more difficult to understand is exactly when should it start, exactly what should we do. And I think the recent team study raised some questions about whether it was safe. We know that we can do rehabilitation activities if someone is mechanically ventilated. We know that we can do rehabilitation activities even if someone is receiving ECMO. What we do need to understand is, what do we do for a patient at a given time point during their disease course? And we need to try to understand what types of activities are safe. In research studies, we need to measure that both in the intervention group and in the comparison group, so that we have a fair comparison to understand safety activities. And we need to understand a little bit more about the severity of the safety events. Things like a fall to the knees or a cardiac arrest or an unplanned extubation. Those are severe adverse events. However, something like a transient drop in oxygen saturation or transient increase in heart rate, those are things that may happen as part of normal care anyways. So we need to start to disentangle that a little bit more. Ron, would you like to add more?
Yeah, thanks. And I think that, as Michelle talked about, it's kind of understanding the way in which we deliver treatments. I think if we were to look back over the 20 years or so that we kind of roughly talked about in the paper to where we are now, we've seen that rapid implementation of early mobilization activities, and I think that probably is the biggest feature that defines the change in physiotherapy from 20 years or so ago, when people were very heavily sedated, and often we might not get involved with anything physical rehab wise until patients were almost leaving the ICU. So I think that introduction of early mobilization, and in conjunction with bringing sedation down sooner in patients, has meant that we can then start to do these treatments with patients. But as Michelle says, now we're at the point where we can take a pause and go, well, actually, let's be more considered about this and just check how we're doing it, who we're doing it with, and when is it appropriate to perhaps not do something as well. So, and that might be okay. Just because we can do something doesn't mean we should. So, as Michelle is alluding to, we need to just now start to be more considered about selecting patients and who and when and what. But I think maybe the other feature that I would observe clinically has come through is adjuncts such as Michelle is investigating, things like cycloergometry, those interventions that you can use when patients are still very early, acutely ill, not awake, not actively engaging. And that also feels like a key feature of physiotherapy that's come through in the last, in the last kind of phase of our professional development around bringing in these early adjuncts. But again, we still need to understand how and why and who that should be delivered with. So we seem to have developed all of these brilliant techniques, and now we just need to hone in on how they're working.
Sometimes I think that people they want explanation for our interventions and the outcomes that we get, and sometimes when we bring some scientific information, people try to change it. As you just said, we know that we got to start early mobilization as early as possible, and that we used to do that when patients are awake, and then people just stop quitting getting close to the patient that are not awake. So we need to understand, do we have intervention, the cycle ergometer or stimulation, electrical stimulation? What can we do for that kind of patient? Or is it really not getting close to this patient? I think that we are going to the future where we have some big topics clear, but we need to understand small topics so we can make a better approach for the patient. It's like when you go to the doctor, not every time you go to the doctor, you want to get drugs when you go to the doctor. Sometimes you go to the doctor and the doctor says, you don't need drugs, and say, oh, that's a great doctor. Thank you a lot. I'm good. So sometimes you need to get to the ICU and tell the patient, you don't need physical therapy intervention. And then he's going to say, okay, that's great. So I'm going to walk in the ICU by my own. I'm going to sit down. And I hope that's something we get to the future.
And I think that speaks to, we hear about the term personalized medicine, and Michelle mentioned this earlier on around personalized rehabilitation. So what does it mean for an individual patient? When should they have physical strategies, but also, we don't just, it's not just physical rehab on its own, that impacts with nutritional therapy that's delivered to patients. And we know very much that the way in which we try and exercise patients is hugely influenced by what their feeding is, what their nutritional status is. And the two of those probably need to go hand in hand. We don't just think about, we might test some of our physical rehab interventions on their own, but the likelihood is they, of course, don't work literally on their own. Have a very deconditioned patient, who isn't feeding well, for want of a simple phrase, then they may not respond well to physical rehab strategies. And also around engaging their psychological status as well. So for some patients, as we know, they can feel so anxious and low mood, and the trauma associated with being critically ill can massively influence how they participate in rehab activities. And so again, we could do something, but perhaps it's not helping or it's not as effective as it could be, simply because the patient's struggling to engage because of their emotional, their psychological experiences or difficulties. And maybe we need to bring in support for that aspect to help them then engage. So I guess I suppose what I'm trying to say more easily is that whilst we might look at our interventions in isolation, the whole system is complex, and one relates to the other, and maybe it's multimodal in the future.
It's also interesting to consider what types of interventions and the opportunity cost of doing some of the interventions. So in Canada, we are facing a shortage of physiotherapists for the demand that there is right now. And if we are considering different types of interventions, such as muscle stimulation or even use of the in-bed cycle ergometer, there is the opportunity cost of the time to set up the equipment. Something like electrical muscle stimulation requires monitoring to ensure that the muscle continues to contract. And is there an opportunity cost for doing that intervention versus the opportunity of the physiotherapist's time to be doing other activities? So it's trying to understand a very complex setting and helping others who might be thinking that, oh, well, we can do muscle stimulation, it's early and we can do this for an hour or whatnot. But that is an hour of the physiotherapist's time that might be spent doing other things. So there's lots of complexities that we need to disentangle around what we can do in the ICU, and we're not technicians. So we're well educated, we can contribute to the team, and I think we need to have a voice to help people understand what types of interventions to test and who's involved in providing those interventions.
Yeah, and in this way, I would like to hear you about the other topic that we has been talked about in Brazil, about the terms and the topics. The specific topic is mobilization and rehabilitation. In Brazil, you have been talked about this. And I would like to hear you about this. What's the difference? Is it important? Because I believe that in clinical practice, for example, considering teamwork, it's very important to differentiate between mobility and rehabilitation, physical physiotherapists and nurse. But in the other hand, it's known that, if, for example, early mobility is well established as a keyword in the researches. I don't know, I would like to hear you. Is it important to different this now? What is the importance about this?
I think it's hugely important that we get the language right, and especially when we're thinking now about being more precise with what we're doing and what we're referring to, and also when we're doing research, being very clear about what intervention we are testing the effectiveness of. So I think Deborah, you're absolutely right. It is important, and again, it's one of those things where maybe it doesn't feel like it matters if you're just watching someone from the outside, but actually, it is vital that we all understand what are we referring to, and are we using the same words to refer to the same thing. So rehabilitation is a really broad term. And it has its own definition about restoring patients to kind of their normal activities, participation, etc. So bringing someone back to kind of full function, as it were. But within rehab, you might have then physical rehab, you could have psychological rehab, you could have nutritional therapy, etc. And then mobilization is just one of in our armory of physical rehab approaches. Michelle's program of work particularly investigates cycle ergometry as another physical rehabilitation strategy. So mobilization isn't it's become synonymous with rehab, but I think probably because in ICU, when we first started to realize that patients could do more and we should be engaging with them more, physical rehab was the first bit that got going. I think that was kind of the first part of rehab that really started to be explored. So I think the two things became synonymous. If you said rehab, you meant physical rehab, and that actually meant mobilization. But we do need to separate them now. And mobilization has a very specific meaning around moving patients, and we have some very simple scales. The ICU mobility scale, most commonly used around kind of helping to just simply categorize what mobilization activity the patient's done. Early, and I say early in inverted commas, because nobody knows the definition of early. Is it within 24 hours of admission to the ICU, 48 hours of admission to the ICU, or indeed, is it relative to when the patient is stable enough to begin to do any activity? So forget the time point of arriving in the ICU. Let's maybe look at the patient themselves. So that's not defined either. So I think it is really important that we are clear about what we're describing, both in clinical practice and especially in research, when we need to be clear about if we're saying whether or not an intervention has worked or not, then we need to know what was the intervention, because you can't just say rehab doesn't work. What we're testing is one specific intervention that looks like this, and that may or may not work, but that doesn't mean that another physical rehab intervention might have a different result. And I'll stop there and let Michelle.
Well, it's interesting thinking about rehabilitation and mobility, and I credit Sue Burney for challenging us to think about the distinction between rehabilitation and mobility. And from an ICU perspective, no one, quote unquote, owns the patient. So I would say that mobility is something that would be ascribed to the whole ICU team. There is no reason why someone can't move in the ICU, and it's not the sole responsibility of the physiotherapist for someone to move in the ICU. The activities that occur for both mobility and rehabilitation may be the same. And when Bronwen and I were working with Sue on this paper, Sue identified that for it to be rehabilitation, a patient needs to have a specific goal that needs to be remedied. And physiotherapists have the skills to conduct the assessment and more in-depth inquiry to understand particular impairments that a patient may have that could be more amenable to specific physiotherapy interventions to improve their outcomes. So trying to distinguish between the two and recognizing that there is a lot of overlap in what activities may be considered for mobility and also for rehabilitation, but distinguishing that for rehabilitation, a patient needs to have a specific goal. If we think, for example, if you have a patient who has been admitted to your ICU because they were choking and had to have a short bout of mechanical ventilation, but then otherwise were extubated, that person most likely would not require rehabilitation, but they could be mobilized. In contrast, someone who is admitted to the ICU with progressive decline in function, has pneumonia, and then is on bed rest for 5 days, mechanically ventilated, and develops progressive weakness, perhaps develops some ICU delirium, that is perhaps more of a candidate for rehabilitation because they will have specific goals.
And let me try to spread the question. And on this scenario you just told us, so mobilization is always going to be inside a rehabilitation program, but some mobilizations can just be mobilizations without being in a rehabilitation program. We don't have a rehabilitation without mobilization, but we have mobilization without rehabilitation.
Exactly.
Absolutely. And as Michelle describes there. I think it's partly around also our decision making, our clinical decision making, and our assessment around the impairments that the patient has. So the benefit of being in the ICU team is that we all bring our individual specialty to the patient. So for physio, we're looking around, is it balance? Is it proprioception? Is it, coordination? How do we help? What particular muscle might need to be assessed, to help someone carry out a particular task? And we look to see how do we rehabilitate that? How do we therapeutically deliver an activity and intervention to target that particular impairment? And that might help the patient progress from one mobilization level to the next. So sitting to standing to stepping to walking. If it's simply a technical task, you don't, as Michelle says, you don't need necessarily a physio to simply stand someone and walk them, but you may need the therapeutic expertise that we bring if they have an impairment that's stopping them from progressing from one to the other, or to optimize their performance. That's when we bring our physiotherapy skills and our training and our expertise to the therapeutic delivery of that, rather than simply the technical carrying out of a mobilization activity that anybody could do. I think that's where we hone in on, as Michelle says, those particular patients that need our skills.
It's probably something that we need to work better for the future, is that we have this skill, this ability to get an intervention with mobilization, but therapeutic mobilization, but we also need to work on the team as leadership, as full member of the team, to make the decision, this is not therapeutic. So other professionals in the ICU, that you got to mobilize this patient, and that's not therapeutic. For example, as this patient that just choked, then he's able to walk, or she's able to walk. They can walk on the ICU, they can sit on a chair, they can go to the bathroom, and they can bathe themselves. But as physical therapists, as rehabilitation professionals that get these skills, you both told us it's on your paper, and we have to make the decision to say that's not therapeutic. I'm not going to make this intervention, but other people need to keep up with this mobilization. We have some authors that lead to the complexity of the mobilization demands different professionals. So it's a really complex walking. You need the physiotherapist and the occupational therapist. But if it's a simple walking, anyone can bring that for the ICU. I think that's one really important thing that we need to improve for the future.
And I think we've had so much turnover in ICU staff. One of the things that we'll need to do too is educate people. So we may receive an inappropriate referral for someone who has independent baseline, is in the ICU for something short and reversible. And if we are consulted, then that's the opportunity for us to educate the other professionals, to help them understand, here's some of our clinical reasoning for why a physiotherapy consult isn't needed at this time. So then we can empower them to help them understand what their role is. Also being sensitive to the widespread human resource shortage in nursing, and understand how we're part of that team. So it's a very delicate balance, but certainly I can speak for my hospital, we have wonderful, wonderful nurses, and it's fantastic because we've been able to establish a culture where the nurses who have come now from different parts of the hospital are used to mobilizing patients. Then they'll involve us when the patients are a bit more complex. But if we do have someone who is providing coverage and they're not as sure, then we have an opportunity to help them understand what our role is and what we can offer to the patients, whether it is working with them when they're mechanically ventilated, or working with them or empowering them to allow them to be as independent as possible when they're in the ICU.
Okay. And we have 46 minutes more or less of talk here, and I don't know if Deborah has one question. I have one question about the future.
Yeah.
Can I make it?
Yeah.
And you have described a lot of things that you believe for the future. Some of them we have discussed here. That's better decision, understand scientific evidence, and all that. And you have talked about technology and get involved with other professionals. Is there something for the future that any one of you both you believe someday we're gonna have in the ICU in the physical therapy, but you haven't put on the paper, and that's something you dream about?
I'm trying to think if there's anything that we didn't actually put down.
Something you didn't describe.
Yeah, I can't see anything, well, so from my perspective, nothing that I guess we hadn't perhaps described, but just thinking around what will our ICUs look like, and the fact that we may, our role will continue to evolve, and what intensive care looks like in the future, in the next 20 years, we will need to continually look to see how does our role fit in with that. So you mentioned at the start, Saint-Clair, about profile of physiotherapists, and I guess I can see us how our profile will shape and mold and change as ICU changes. And so Michelle and I thought about things to do with our profession, but within the bigger context, we'll need to be flexible and adapt to what ICU looks like. And of course, we saw some of that in the pandemic with the shifting, very acute situations around what ICU, where it was, what it looked like, etc. I can see probably how in the future we'll continue to change with technology, different skill sets that physios have and may have the opportunity to acquire, but not losing sight of what our fundamental skills and expertise are that we can bring to the patient. So I'm not sure if I've totally answered your question, but I think that's maybe what I might see.
I think for physiotherapists, because we do have such a varied skill set, I would be excited to see physiotherapists be in roles that are non-traditional. So perhaps being involved in palliative care and end-of-life care. I would love to have a system where anyone who is admitted to an ICU is automatically enrolled in a rehabilitation trial, so that we can identify different types of interventions, and that the physiotherapists are actively engaged and involved in answering the questions about which interventions work. And they're involved in shaping the questions and helping to set the research agenda for and with the patients, so that we can really start something in the ICU that would then continue beyond the ICU and into the community. So thinking back to Bronwen's earlier comment about this continuum of trying to improve the patient's quality of life from the ICU back into the community, thinking about where research can occur, and thinking that if we can have every patient that's admitted to an ICU involved or enrolled in a research study, so that we can improve the care for them and people like them in the future. And if physiotherapists can be part of that, that would be a wonderful way to advance the profession.
And for that to be national.
Yes,
so,
absolutely.
We've learned that from team that can be done. Michelle's doing that in Cycle. So we should be harnessing all of the expertise that we have around the world. Today we're sat down and there's from Brazil, from Canada, from the UK. So we will need large numbers of patients to answer some of these questions because of the complexities of the interventions and thinking about the outcomes and so the numbers of patients that we will need is large, and we can only do that if we work together. And wouldn't that be fantastic collaboration for us and for our patients?
And wouldn't it be wonderful to embed that as part of a the platform trials. So we have so many platform trials that are already existing in our ICUs. And certainly the recovery trial from the UK was a huge contribution to helping us understand treatments for COVID. Wouldn't it have been amazing to have had some rehabilitation also studied during the course of the recovery trial? So trying to think proactively about how to embed rehabilitation interventions into existing research, because that's what's already happening in our ICUs.
Yeah, sure.
We had the setting. We
important.
had the setting.
Yeah, yeah. Unfortunately, we need to finish our episode. It was a fantastic conversation. I'm sure whoever listens to us will enjoy a lot of high quality of this episode. I would like to thank you again for your presence, for your time, and I hope to meet you soon in person at some time here in Brazil or in future Congress the next year in European Congress of Rehabilitation. Thank you very much, Saint-Clair.
Thank you, Michelle. Thank you, Bronwen. It's, as I told you at the beginning, it's an honor to receive you here. And as Deborah said, it's a high quality talk, conversation. And I hope it gets to inspire a lot of people to think about what they are doing in the present and what do they expect for the future. So I thank a lot your time and being available to talk to us. We have one thing that we do in some episodes that we ask our guests if they have some tips for the people that listens to us, and tips that are outside technical tips, not an article, not something like that. And as we have talked here, I was thinking about what should be my tip. And as you both told about meaning, what's the meaning of the interventions we are doing, and we are talking about the past, the present, the future. So my tip is everyone watch Back to the Future again, the 3 movies, because Back to the Future is what we are talking about. He has a meaning, and Michael Fox, he has a meaning, and he gets back to the past, and he wants to correct things, but everything is complex. So when he does any change in the past, it just brings a big change for the future, and good or bad. So I think that if someone that's listening to us has not watch it Back to the Future yet, watch Back to the Future and think about the physiotherapy in the ICU. So I give you the word so you can bring your final comments.
I love that. I think that's brilliant. And it does really actually emphasize everything that we've tried to cover. I think we have, in order to look forward, you sometimes have to look back at what you've learned and what you've done, and let that shape how you move forwards as well, as well as being open to what new things arise that and be flexible to adapting. And that's how we will continue to develop and grow our profession, as if we are open to allowing it to evolve and develop. And I'd just like to say thank you for the invitation to be part of this. It's absolutely fantastic, and you are doing brilliant work in your own areas as well. And so we learn from each other, and thank you for having us today and giving us the chance to have a fabulous conversation.
I echo Bronwen's compliments and congratulate you on this wonderful initiative. It's a lot of work to do, and it's so important for our field. And I am grateful for the opportunity that we had to reflect back and learn more about our profession. And I marvel at the people who came before us, who have really set the stage to allow us to be able to do what we're doing now. And I hope that we might be helpful for others in the future so that they can learn from us and continue to advance our profession.
Yeah.
Thank you. Thanks a lot.
Thank you for everyone, and see you soon. Bye-bye. Thank you.
Bye-bye. See you soon. See everybody in the next episode. Thank you.
Yeah.